I'd like to introduce our second keynote speaker, who's Associate Professor Neil Orford. Neil is a Senior Staff Specialist in Intensive Care at University Hospital Geelong. His interests include clinical leadership, communication, clinical research, philanthropy, and writing for the public about the human side of healthcare. Neil was the Director of the University Hospital in Geelong ICU from 2008 to 2020, overseeing the move into the new 24-bed ICU and the development of the commencement of the paediatric ICU and ECMO service, and the iValidate program, which I'm very much aware of. Neil is a Board Director of the College of Intensive Care Medicine of Australia and New Zealand, and his roles include Lead of the Culture in ICU Program, Deputy Chair of the Hospital Accreditation Committee, and Deputy Censor. So he's a busy guy. So thank you, Neil.
Thank you. Now, since you've been sitting here for a while, I will make myself unpopular because you've got 20 minutes to sit here till you get to morning tea and wake you up. So what I want you to do is look at the person next to you, ask them what they value, and then sit in silence until I tell you to answer it. So, and preferably in that silence, you'll look at each other. Now, you don't have to stare in your eyes lovingly. You can, I don't mind, but I want you to look at each other, and then when I say, you can answer it. And just 2 or 3 words of what you value. If you speak during the period that you're supposed to be silent, I'm just going to reset the clock and we'll be here all day, children. Okay, so sit and ask the person next to you what matters to them, and then I'll tell you. I'm ready. Ask the question. Okay, and silence. Look lovingly. Okay, answer the question. 2 or 3 words to each other. Okay, I better stop you. I've lost control. Okay, everyone, thank you. I'm sorry, I better stop you there, but so that took you 30 seconds, okay? It's very hard to get people to do that in a hospital. So we cannot sit in silence and listen to people for, you waited 8 seconds of silence. I don't know if it felt uncomfortable or not, but that's hard to do. And so for that 30 seconds, you'll see, we'll get onto it. So thanks to the Western Alliance for the opportunity to speak and for attending today, particularly to Drew and Cass for patience and everything. And over the next 20 minutes, I'll try and describe what we're trying to achieve with the iValidate program, what we've done, what we'll go next. Now, you're looking at the painting called Kalpiran Kalkutan by Taryn Love, with her permission. She's a proud young Gunjat Marakire Wurrung woman from Western Victoria and very close to my family. Kalpiran Kalkutan translates as the silent dead. The painting, which was her IB Year 12 painting, of which she got 100%, which is very difficult to do in IB, but this was painted by, I think she was 16 or 17 at the time. The countless indistinguishable figures convey our dark and violent history, the breaking of culture. Now, art of course has many meanings, and as well as the crucial Indigenous message. This painting reminds me of the duty I carry to all who have died in my care. So I would also like to acknowledge the traditional custodians of the land upon which we stand, the Jabberong people and the Gunjat Mara people, and their enduring connections to land, waterways and cultural sites. I pay my respects to elders past, present and future, for they hold the memories, traditions, culture and hopes of Aboriginal and Torres Strait Islander people. So iValidate what we're trying to do is improve care for people who are at high risk of dying in our hospitals and our community, ideally, by teaching healthcare professionals to ask and listen and then incorporate all that into care. Sounds really simple. Took you guys 30 seconds. But we probably need to make sure that we're talking about the same ideas, because what I've learned over the last 10 years is that we're not, that we all hold a very different idea of what person-centeredness and shared decision-making is. So a few years ago, a 78-year-old woman came into our hospital with worsening of her underlying lung disease, a precarious situation to be in when you're on home oxygen, admitted to the ward, got a bit worse, a bit more breathless, working hard, got referred to ICU in the middle of the night. It's a very common occurrence. So the ward doctors and nurses were worried they couldn't reduce her work of breathing and keep her comfortable, and felt distressed. The ICU were worried that we were about to be asked to ventilate an older woman with end-stage lung disease and who's dying, and give her a burdensome and bad death. So we felt distressed, and the patient and the family were worried because they just wanted her safe and comfortable. So there's a lot of emotion below the surface there. What would help is a document that addresses all these worries, this history we've got that's written down, and guides us what to do in this exact scenario. Don't worry if you can't read this stuff, I'll talk to you through it. They're just pictures in which we find ourselves. So what we want is some sort of patient voice. And she had a goals of care form, a written record of person-centered care. Now I see countless versions, thousands of these a year, and I see hundreds like this. And remember that when we meet people, most of the time they're either too breathless or distressed or too unconscious, or their relatives are too anxious to go through all this easily and arrive at the same sort of answer they would come to if we talked to them when they were less distressed. Doesn't mean we can't do it, it's just not easy. So is this okay? A box is ticked, HDU down the bottom, it tells us what to do. Is this what we want as our version of person-centered care? So let's just all shared decision-making. Let's sort out what is shared decision-making. So I think of it as the operationalisation of person-centred care. So most simply, a sort of bridge between autonomy and paternalism. So on one hand, we've got patient voice, their goals, their values, their preferences, what matters to them. And on the other hand, we've got the advice and the expertise from our highly trained health professionals. And in shared decision-making, we bring it together. Then we deliberate, discuss, work out what's unacceptable, expectations and all that, and come up with a plan together, which we then document so we know what to do. And although it's just a bit of paper, it does matter, because it is that written record that tells us what to do when we can't find people. So you won't be able to read that, but back to our friend on the ward. So what we saw before wasn't shared decision making. There is no patient voice. Doesn't want CPR is not a value. That's just us writing something to fit with the box we tick, which is HDU. So there is no sense of her. One of the iValidate trained doctors came and saw her, and we got a really clear picture. So she likes living with her husband. Wonders never cease. She's frail. She knows she's frail, but she loves her dogs. I like that she likes living with her husband, but she loves her dogs. We don't want to go into that. She likes doing stuff around the house, the dogs. She even likes small house chores, like cooking and putting out the washing. Like, where is she when we need her? She's limited by her breathlessness, and her joy and happiness in life is dependent on getting back to that. And then it talks about her not wanting to be ventilated, knowing that if she does, that she'll never get back to that. So that's unacceptable. She's had non-invasive ventilation before, didn't love it, but prepared to give it a go. And so a really nuanced plan came out, and that's good. So if you're a cynic, you would say, whatever, that's nice, lots of words on the page, you still ticked HDU care, doesn't make any difference. I think it does. I see a lot of families and patients who are distressed by poor communication and staff. So on one hand, you tick a box and then you spend the next couple of weeks talking about it in conflict and making less than ideal decisions. On the other hand, you discuss it all and have this very nuanced, collaborative approach to some very critical decisions. So I think I know that. I'm sure I know it. What I want us to do is prove it. And so that's how iValidate started. And there are questions we have to ask. Does any of this matter? Does anyone care? Is there a problem? Can we teach and support shared decision making, and will it make any difference? I think it matters. So Atul Gawande thinks it matters, and he was a bestseller. There are trials, so the impact, if you're an academic, it matters. So the impact of shared decision-making papers is going up, and there are now trials in the New England Journal, our highest impact journal, looking at interventions in sort of step wedge cluster design trials. It's a part of our standard. You know, you get accredited on this. It explicitly talks about shared decision-making and identification of values and goals, yet we don't do that routinely. So I think it matters. So the rest of it was then us trying to answer those other questions, and that's just me in love with Canva. Like, I don't know if the rest of you are, but I have, at the months I've wasted on Canva for stupid looking pictures. Anyway, so over the last sort of decade or so, we've gradually built up a research body of work to go with our education and implementation. The start of it was all about observation and just trying to work out what the problem was. The middle was a bit of fine-tuning, and we're now looking at sort of before and after interventions. And on the right, the sort of 9, 10, 11, 12, 13 are all the projects that are running. Oh, and the 13 came up twice. How unlucky. All the ones that we're working on now, which are, we've got some 5-year data of what it looks like when you do this in Gen Med and ICU, some aged care. We're linking to the ANZIC's core database registry in Victoria, high-risk surgery. And then what we're trying, we'll get to the end, is what's the next step. So just, again, don't worry about the pictures. So is there a problem in our hospital? So there is. So we've got 3,840 patients in our iValidate registry. The first thing we wanted to know is, can you actually identify people who are at risk of dying? Which sounds like you should be able to, but there are really good community-based life-limiting illness criteria based around sort of frailty, untreatable cancer and organ failure, and we wanted to make sure that you could use them easily in a hospital system and identify high-risk people, because you will be surprised, and there were some critics of this at the start, that maybe it was just ICU trying to push people out of intensive care, which it isn't. And so what we found is about a third of patients in the hospital, a quarter to a third, have a life-limiting illness, which means they're sort of 50% chance of dying in the next year. They spend a long time in the emergency department. They are more likely to get admitted from the emergency department. And at baseline, back in 2015, when we looked through all their medical records, and we were pretty generous about this, we went through all their notes, in less than 10% of patients could we find any reference to the patient as a person. So that's appalling. And that's the same all around the country, if you go looking. So that was good. We knew what the baseline was. So then we developed a program, and I have to, Barwon Health has been incredibly generous to support this since 2015, where we sent we were lucky, we had Peter Martin and Jonathan Silverman sort of in Deakin. If you don't know, Jonathan Silverman's the sort of founder of the Calgary-Cambridge communication method. So we sent people over there, and they became really good at it. We sent people to Harvard to do the difficult conversation course. And then we built our own faculty, and we've got this very expert group of faculty. We have trained a lot of people. We built this 2-day communication program with small group workshops and simulated patients who are very skilled actors, and have run it, for the last, whatever that is, 7 years. And we're up to, I think, 1,200 now. A lot of it's Barwon Health, but we've done it in other communities. We do it with renal patients in New South Wales and palliative care in New South Wales. We spent 1.5 years in Aboriginal communities in the Northern Territory working with them about end-of-life discussion around end-of-life care. New Zealand, we've got colleges endorsing it. So it's growing, and it's got a reputation as an educational intervention. Next to it, we built a sort of process of care, and with stepped you through sort of identifying patients. Do they have surrogate competency or capacity? And if not, who's their surrogate? Identify their goals and values, deliberate, or give medical advice, deliberate, discuss, document, We also refined this over the years, and this is kind of my favourite bit, is we did this thematic analysis of, I think, 350 goals of care form to look at what language was emerging about values. And although there are themes on the left about connectedness, autonomy, and balancing quality and quantity, and etc., it's those sub-themes which I think we've found a framework of values that matter to people. And just as you can see, the one that matters the least is longevity. Now, we knew that, but it's not, I'll get back to that. And so we have these themes, so relationships, like we kind of knew that mattered, but not everyone talks about it. Being at home, so place, that's not something that's commonly talked about in hospitals, and in my experience. People mistake place for independence quite often. So we know that there are lots of patients who say, I don't care about my independence, I'm happy to, I just want to be at home. And you know, if you have to do stuff to me at home, that's okay. Enjoyment of activities, that's the nicest thing, all these things people like doing. And you know, you can see them all there. Longevity rarely comes up unless you haven't explored the other values. And longevity currently is only being brought up by surrogates who probably are having trouble and just, you know, aren't trained for this. And so just reach for longevity as their sort of default. And, you know, we've listened, so those words may not mean anything to anyone, but I've been involved in some of these conversations and they really matter. You know, we heard about this guy who wanted to go to the Gold Coast, a very complex plan with his 3 adult children before he died. So all of that we made into a process of care, and Barwon Health helped us make a process of care form that's changed but sort of follows you through it. We made fancy, you know, implementation things about nudging and checking and how to make it work in the wards and ICU. So then we started seeing, does it make a difference? So I think the first question, will it change doctors' behaviour? And we're just looking at the last 5 years of iValidate for doctors. I think it does. So on the left is iValidate. This is what a goals of care form looks like between an iValidate trained doctor and a non-iValidate trained doctor, and they are outperforming on every aspect of shared decision making. It's not surprising. So they identify capacity, they identify values twice as much, they give more advice. But the lovely bit is that they do all this values, goals and preferences. They find about relationships, place, independence, all of it more. They're more likely to make a form, you know, end up with a shared decision-making process completed, like 67% versus 27%. And that bottom bit is, it looks like you just end up with more registrars and consultants. You're not supposed to be doing these as a resident, but I suspect what we're really seeing is the unknown 35% are just getting allocated somewhere. But that unknown, so 1 in 3 not being signed off, means it's an invalid document, and when we get there in the middle of the night, we look at it and think anyone could have written this, it's of no use. So it's making a better form in every way. We also we defined what a shared decision-making admission is, and the factor, and this was with about 600 patients, and the factor that is most associated with shared decision-making, above diagnosis, age, and a whole lot of other variables, is being exposed to an iValidate trained doctor. That's a ridiculous odds ratio, but it's what it is at the moment. It doesn't surprise me, because if you're not trained, you just don't do it. Does it change decisions? That's kind of nuanced. So everyone was worried that we were either excluding patients from ICU or we were going to have a tsunami of patients in ICU. I don't think it does either. We've looked at access to ICU, it doesn't look any different. In patients who are in intensive care on the left, more of them choose ICU and HDU as where they want to be if they deteriorate. What's really happening again is that 35% not decided have been reallocated to going somewhere. So they're going to end up with this anyway. But they all would have, that 35% would all default to ICU in the middle of the night when we don't know what to do. So it's giving us and the families some certainty in planning, and that feels important. We're just doing an aged care resident program analysis now. We sent iValidate ACP nurses, trained ACP nurses into the Barwon Health aged care facilities during COVID. And what we found is they identified more values and everything, but they also, the choices were much less hospital-based. Now that's so overwhelming, it just goes to show that if you ask people, they will probably tell you that they want to stay at home rather than go to hospital if they're near the end of life. But still, if that had played out across all the 8,500, whatever it is, nursing home beds in Western Victoria, if things got really bad, that could have, and if we'd been able to supply them with good palliative care in home, that could have made a massive difference. So to change outcomes, mortality is not the goal of end-of-life planning, as in not dying, it's not the goal of end-of-life planning. But there was a little bit of concern that we were just trying to exclude people. All we've seen so far is that in before and after that mortality improves. Now there is evidence in palliative care literature that good palliative care improves survival, short-term survival. I'm not sure we're seeing that. This could just be as simple as the patients who are getting admitted to ICU are changing a little bit from patients who were definitely going to die to patients who are not going to die and respond better to ICU. It was a small survey, but at least it would have created some barriers if it had been really bad. What we want to know is, are people dying well and living well at the end of their life and in the right spot? Economic analysis and hospital outcomes we haven't done yet. The signal's there, so 5 years of gen med patients, days in hospital, went down over the 5-year period. Could have been due to other things, but also person-centred care and shared decision making went up. That's a 2 to 3 day reduction in stay. There are about 400, at least 400 patients admitted to gen med for life-threatening illness. That's 1,000 to 1,500 hospital days. I think that matters. And then for frailty patients, we just saw a reduction in METs, which is good for us because we don't have to hang around and run around the hospital as much, and a decrease in 90-day readmission. And that doesn't surprise me. Frailty patients often don't have much that's fixable, and it may well be that if you talk to them and plan it, they could have care out of a hospital. So then I just Canva, I can't help myself. That's just the sort of the systematic approach to this. And so what we've tried to do is, that's all the stuff we just talked about. So when we just change the form, if you just think, because people said to us, it's expensive running an iValidate sort of communication 2-day active-based program. If you just change the form and put it in the wards, nothing happens, other than you get a little bit more paternalism because there's more boxes to tick. Step 2, if you train the nurses and doctors, you get much better identification of values, and that won't surprise anyone because nurses and allied health know everything about patients and families. Unfortunately, the nature of those forms is that they're reluctant to fill out the values section because you've got to sign the bottom. So we have a problem there. We're just trying to work out, ideally, how do we harness this information and have it available. If you train the nurses and the doctors, you get an increase in shared decision making. And then if you put clinical support, so the top is gen med, we sent iValidate staff up to the gen med wards over 5 years, trained staff, particularly during COVID. And all those things are just measures of person-centred care, values, concordance. It all improved. And that was nudging, daily reminders, feedback loops. ICU the same, as we nudged our way up over 5 years, we saw improvement. Hopefully we'll see the same in aged care. So we're missing something, which is patient voice in follow-up. So this is a longitudinal study we did, a long-term follow-up study we did with survivors of ICU, where we interviewed them at 6 or 12 months, and it was a qualitative study. And it was really interesting, all the stuff we found about the themes of recovery and the facts that bother them. We are yet to do that with iValidate. We don't have shared decision-making experiential measures, and we haven't interviewed people only just because we haven't had the resources to do it, but it's a problem. The other big problem is goal concordant care, which is the sort of holy grail of shared decision making, where the care, where you identify a patient's goals. So I might say, I want to be, watching Netflix tomorrow, in 6 months' time, and you come back to me at 6 months' time, and we work out what care plan you're going to offer me based on that. If in 6 months I'm not watching Netflix, it's goal discordant. It's not a win. That's a hard concept. We put in MRFF grants last year for a big sort of cluster randomised trial of Barwon Health. It wasn't successful, and so we're now just trying to work out the next step of how do we scale this. We've got a lot more evidence since then. Is it future MRFF type grants? have we lost equipoise at Barwon Health, and this is a quality initiative that should just be implemented, and how we fund it. And that is the last slide. So I'll just leave you with another piece of artwork, and this is by Taran. This is Mirti Tanto, Ocean Meeting Place. And it's about land and sandy shores and mountainous rainforests and steep rocky cliffs. And the underlying theme of the painting is connection. So the painted lines demonstrate durability and stability, although they are intricate and fragile like our relationships. Thank you.